start. Oh. In case you don't know, my name is Sandra, physical therapist here. Today I wanted to just kind of review a few things regarding mobility, just to review what things you probably already have learned in school, as well as what you do in practice, but just kind of give you an opportunity as well to ask other questions as well, because our patients are always asking to walk. They want to walk more and more and more. So I want everybody to feel comfortable in how we're able to walk with them. So I did make a handout. I only made 6 copies, so we'll make more if we need to. Basically, what I see here over at skilled nursing is there's like a different progression of their mobility. And you guys are great at starting how to get them out of bed into a chair, or out of bed to the commode for the shower chair, or to go from chair to the toilet. So the next step after that would be, when they are capable, they may walk to the bathroom. And when they are capable, the next step would be walking in the hallway, which could be about 100 feet. And then when they're a lot better, we walk them to the dining room. I kind of see like those are like the kind of the 4 phases of what stage they might be at. Always priority is looking at safety for the patient as well as for the staff. I want to cover a few lingo words that sometimes I think might get confusing, as well as maybe we all went to school in a different place and we use different words. So you might see us write down CGA, and that stands for Contact Guard Assist, meaning you don't have to hold them or lift them, but you should be within arm's reach in case they lose their balance. We might write MIN Assist, MINA, and that means approximately they might need 25% of help for their transfer or their walking. Goes up to moderate, up to maximum assist, meaning you might be doing 75 to 100% of the work to get them up. So different assistive devices out there. We call this one an FWW, for front wheel walker. You might also see rollator. I put one in the hall. We'll look at that later. That has 4 wheels. There is single point cane, quad cane, which has 4 feet, hemi walker, Hoyer lift, and then there could be easy stand or Sarah lift. So those are different kinds of things we might see here at skilled nursing. So I'll just bring in the other ones. So this is the hemi walker. Usually we use it if they only have one arm to use. These, they need to have 2 arms to use. Quad cane, I didn't bring that, has 4 feet at the bottom as well. Okay, so before you could even walk with them, we have to prepare them to stand up. So I'll pretend to be the patient then. I think it's really important that we give them the verbal instructions to tell them what you want them to do, because that will really help them follow and work together kind of like as a team. So I say step 1 is to scoot forward on the chair. Get to the front. If they try to stand up from the back, it's going to be really hard to get up from the chair. So get them to come to the front. That's step 1. Step 2, bring their feet in. If their feet is way out here, I also can't get up from here. So sometimes the foot rests, you take it off, and their feet are way out in front. So they really have to get their feet inside. Once they're at the front of the chair, this is a great time to put the gait belt on, because now they're not leaning right up against the back. Right? If you try to get the gait belt off when they're slouched, it's very hard to get on. So I would recommend it always to use the gait belt. It just gives you an extra handle on there. They're slippery, they're wet, their pants are loose, they're not even pants on, nothing to grab. So the gait belt really is an extra tool to steady them, but not to lift them. The next step is they should put their hands on the armrests or on the bed to push themselves up. Now, if they choose, they always have the tendency they want to do this, but they're going to pull on the walker and the walker's going to move. So they really should push from here. And if they really want to have one hand up there, then they can have one hand here, but your hand should be on the other side to steady the walker. Otherwise, the thing is going to tip over. All right. And then when they get to here, you tell them to straighten their knees as well. And also, I would suggest when they get into this position, don't just go 2 hands over. It's kind of better to go one hand and the other hand and then straighten out. All right. I did write on here other ways to transfer from bed to the chair. They might do a pivot transfer. We're not really going to talk about transfers as much today, but we may indicate that it's better for them to use the walker to transfer and not just do a pivot transfer. And sometimes we might indicate if they should go towards the left or towards the right. We might give that suggestion. Okay, so in terms of ambulation, when we ask to increase their ambulation as part of their ADLs in the room, it's because they've been practicing consistently in therapy already. So they know the steps that they need to do to walk. They've been practicing, and we're confident that they can do it without a lot of cueing and a lot of physical help. So when I teach you guys to help them with ambulation, everything you tell them to do, they should already know it. So we wouldn't upgrade them to ambulate to bathroom unless we're confident that they can consistently do it already and that we've been practicing already in the bathroom, or they can walk a lot further and then we're just starting with the bathroom. Okay. And they're going to be excited to walk to the bathroom instead of taking the wheelchair. We might communicate that upgrade for their walking. We'll either write it on the whiteboard or we'll write it in the chart as well so that it can get into matrix, and we'll often verbalize it with you guys as well when they're upgraded. So when I upgrade them to walking with nursing staff, I should tell you what level assistance they need, what device they need to use, and how far can they walk. So those are the three things. If we don't tell you that, then you need to let us know that we didn't tell you that, because that's what you need to know. And it really should be contact guard or maybe min assist. If there's anybody that's heavier walking that needs mid or moderate or maximum assist, we're not going to assign to nursing to walk because they're not ready. Okay. So before you even get them to walk, you want to get the area ready. So clear the path. So part of walking with patients is looking out for safety awareness, things that they might not realize. There's a garbage can in the way, there's a footrest on the floor, the bed table's in the way, something is in the way. So I would get as many things ready as you can beforehand, get the walker ready, prepare the patient with proper footwear. Do they have the non-skid socks and or put their shoes on? And if they're in a wheelchair, you want to make sure that the brakes are locked already. I said this before, guide them with verbal instructions on where they're going to go. Do you want them to turn left or turn right? And often it's also because they have very poor vision and they don't quite know which way you want them to go. So when you're working as a team and telling them that you're going to be turning left now, it often helps. Okay, so just a few tips about walking with patients, whether it's to the bathroom or in the hall. You want to remind them to always stay within the walker. You don't want it to get out too far in front because it can run away. And you also don't want to be too close to the front because then there's more chance of going backwards. So their body is almost lined up with the back posts. You might notice if they have a one-leg injury, like if they had a fracture, if they had a stroke, or like a total knee or total hip, we teach them first what's called step 2 patterns. So they move the walker, they move the bad leg, and then they bring the good leg together. So it's walker, bad leg, good leg. So if they're walking, that's kind of how you might see it. It's much more advanced to actually have one foot in front of the other. So especially if they have a lot of pain, they should be leaning on the walker when the bad leg goes down and then step. All right. Now, let's say you're walking. I'm walking kind of fast. And you get to the chair. And then they start to go like this. You say, no. They need to stay in the walker. Have them turn with the walker. And then you tell them back up to the chair so you can feel the chair behind your legs. Then they're going to reach back to the armrest and slowly sit down. So you give them those words, and we've been teaching those words all along already. Okay. What else do I have here? Oh. Other things to watch out for when walking with patients is if they have weakness in their legs, they might have their feet very close together, and that's much harder to balance. So you can give them just the cue, spread your feet apart so that they can be a little bit more balanced. And you might say to them, keep more space between their feet. You don't have to use a lot of detailed words. Any questions so far? I'm trying to be quick here. Now, let me just bring in the rollator. So rollator is a little bit trickier. We would only upgrade to a rollator, which is a lot more unstable when they're a lot stronger. But these are things that we've already taught the patient. They should be doing it with you if they're walking with the rollator. So you would put the walker in front of them. They should know that they should lock the brakes first. And you would do all the same steps of coming to the front of the chair, check their feet, put their arms on the armrest to push themselves up, one hand, other hand. Once they're up and they're steady, then release the brakes. Then they can walk, just as I said. Stay within the arms. I'm not very good at this, am I?
No, you're doing really good.
Back up to the chair. They should lock their brakes before they sit down. Reach back. So they should know all these things already, but it's good that you can reinforce it with them. Okay? All right, we're almost done. Now, in terms of walking patients in the hall, whenever I write a recommendation to walk in the hall, I'm just kind of making a guideline, and I talked to John about this. They should be able to walk 100 feet. That's kind of my guideline. Because anything less than that, you're going to have to follow with the chair, or you're going to have a chair set up someplace. So I'm just kind of giving a guideline, 100 feet, that I'm confident they can do it consistently. But if you need to follow them with a chair, it most likely means that they need contact guard, which means you should be within arm's reach. So if they're standing here, walking with the walker, my suggestion is to have your hand on the gait belt, and then you'll have to pull the wheelchair behind. I feel much more confident and safer when you're with the patient instead of with the chair behind the patient. Now, I know it's tricky. It's not something easy. You know, we all have to build our core so that we can do that. But I think that's the safer way. I would say almost all of our patients should be contact guard. I don't think anybody really is independent and wandering around. Shouldn't be anyway. Yeah, exactly. So just a few other considerations in terms of when you're doing some kind of physical activity with patients is, do I need to check their vital signs? You can, correspond, CNAs can correspond with nursing and resource nurse, but have they had postural hypotension recently? Are they telling you they have dizziness? Do they get short of breath? We would tell you if there's a risk of oxygen desaturation with exercise. It can or cannot happen, but I'm just writing it here as a consideration. Yeah, so that goes along with the postural hypotension. Before you maybe do exercise or walk, for example, for the RNA program, do they need pain medication before they do their exercise? Ask them if they're tired, and do we have a chair ready for them if they do get tired? And then cognition. Are they impulsive? Are they able to follow your instructions? If their short-term, long-term memory, and their safety awareness. So part of the safety awareness is the vision part. So a lot of times some of our patients, they can walk fairly well, but they can't see that obstacle on the floor. And so we can't give them independence to walk to the bathroom, because at home, things tend to be more stable and consistent with the way the furniture is set up. But here, bed tables move, footrests move, garbage cans move, and we can't really give them the independence just because it changes minute to minute how it's set up. So, any questions? No? Okay. You're welcome. Yeah. Good question. So usually what we do, and you're going to have to estimate because you didn't have them stand up quite yet, but it should be at your wrist level so that when they hold it, there's a slight bend in the elbow. So you may just adjust it to what your height would be and then go up and down from what they say that they are. I think that's the important part, is for the resource nurse to get a good report from the hospital what they were doing at the hospital. I can't tell you if they can walk or not if I haven't assessed them, and sometimes it might be 18 hours, 24 hours before we get to them. So really, I think it's a very important question for the resource nurse when they get report before the ambulance leaves the door, is what were they doing at the hospital? Maybe the patient was walking 100 feet already. And because you can't always trust what they tell you. They might say, yeah, they walked to the bathroom, but they really didn't. Right? Reading through the charts, even the transfer orders just says up with assist. It's not very specific what they can or cannot do. It's not until we kind of get into the physical therapy notes where I see what they did the day before. So I know it's hard for you guys to know what they can or cannot do. I think you just have to get the report from the nurse. Yeah. And then you have to check to make sure the vitals are okay. They're not going to have syncope. How much pain are they in? I would say on the safe side is transferring to a chair on the first day and taking the chair into the bathroom. On the safe side.
When they're not supposed to. And then we're like, what?
So you do have to check to see if in the report what their weight-bearing status is. If they're non-weight bearing, it's going to be the expectations of what the patient can do. They're going to really have to have strong arms to walk over. Yeah. Any other questions? I'm always here anyway. All right. Done.
Okay, cool. So those of you guys that missed it or want to watch it, it's gonna be downloaded online. Any questions, guys? Any suggestions?
Thank you.